we talked about guidelines, and that was the curriculum of this meeting. These were staged absolutely on purpose to talk about the guidelines first, the general principles, where we've come from, where we are, and how are we going to, and somewhat the guidance on how are we going to get there. And part of the discussion about the guidelines is there's increasing movement, particularly on our European colleagues, to also have guidelines about the individual patient, that person that's in front of you in that exam room, the emergency room, or that clinical setting, and discuss that individual's blood pressure, treatment thresholds, treatment goals, et cetera. But our European colleagues are a little bit ahead of us. They're doing that, and as you're going to see when we talk a little bit more about the European guidelines, they're now they're saying, well, we need to do that. That's just blocking and tackling, as Dr. Joyner would suggest. That's basics. But we have to do better. We have to actually think about guidelines in the context of not only the individual parameters, but guidelines on how we're going to take care of a population. Whether it's our clinic population, it's our health systems population, region, state, or nation. Or now even, I would suffice to you to say, the globe. And that takes the individual guidelines and puts them into a framework where perhaps we should be developing guidelines on how we take care of this individual patient as it relates to the population, with hypertension control rates as the goal. Not getting that individual person's blood pressure to less than 80 or 70, although, of course, that's job number one. But now I think you're going to see a movement on guidelines coming out that's going to give us some tools or some guidance on how we improve control rates. Because as you're going to see, we are doing extraordinarily poorly, even in our country. And I think that's going to become paramount. It's not there yet, but again, I was in Geneva last week, and now I can announce it, that the WHO, the World Health Organization, has commenced officially the Hypertension Guideline Committee, which I'm on, and which I served as and wrote the background for the committee, for world global guidelines. And that potentially that body may not only issue guidelines that may be applicable globally, but not mandatory, of course, but also addressing how can we improve hypertension control rates in addition to treating the individual. Of course, they're linked. If you don't treat the individual, you're not going to control populations. But there are different ways to do it, coming from an individual level versus coming from a population level. What I'd like to share with you now for the next hour are population initiatives, population guidance, if you will, which I believe is absolutely going to be the standard of practice. 2 years ago, I gave you an inkling of this, and in fact, one member of the audience came up to me and talked to me about that, and even said they brought some of the algorithms, or one of the algorithms, back home to share with their colleagues. That was just an inkling. That was kind of the exception. I'm now going to tell you it's going to be, or I believe it's going to be, a rule. If you follow some of these simple principles, I think, and they're going to be paradigm shifts in the way we practice. But if we can make this change, if we can start incorporating these changes, I truly believe there is evidence now that exists that will tell us we're going to not only treat the individual patient to a better extent, but we're going to treat our population to a better extent as well. So that's what this is sort of about. Long-winded preface, if you will, preamble in terms of what I'm going to discuss now, because it's going to be a change. We are not used to practicing the way I'm going to suggest that we should consider practicing, not only as individual providers, but also as our collective providers, even in a clinic, a building, a health system, a state and country, and now the globe. And some of this is going to be principles that have come outside of the United States that I'm trying to bring back to the United States, to us, because they're working. They're not working in the United States except for rare exceptions. I'll talk to you about some of the exceptions, but we are not used to practicing this way. Why does the World Health Organization have hypertension as job number one for global control? That decision was made 5 years ago, and that preempted my being invited to the first meeting of the Latin American and the Caribbean groups to start thinking about control in our northern and southern hemispheres. That program has now been adopted worldwide, and I'll share that program with you. It's an enormous cost. It's not only a cost in dollars, but it's a cost in health burden. This is a global issue. Hypertension now is the #1 global disease burden in the world. It's not communicable diseases, et cetera, although they're still extraordinarily important. As we just read yesterday, there's another Ebola outbreak in Africa that is extraordinarily serious. But those are small, not minor, not inconsequential. Globally, though, it's non-communicable diseases that are the vast majority of mortality now and the vast majority of cardiovascular disease burden. And hypertension is #1. Modifiable risk factor. That's not to say that obesity is not increasing, diabetes not increasing. Of course, they're all going up in concert as low and middle income countries westernize. They're taking all the bad things about our Western culture and some goods along with them and experiencing exactly what we've been through, only with a frame shift, if you will, of about a generation or two. And that's, you can read this as well. We postulate now that there's probably 1.4 billion individuals on the planet that have hypertension, and that's only the ones we know about. It's probably more than that. And here's the bad news, though. The bad news is that if there's, and this is a little date, this slide is only outdated by 3 years, and already it's 1.4 billion. If I were to update this slide, and I should, and I will. But the bottom line doesn't change. We are only controlling 14% of these are individuals that are diagnosed with hypertension globally. So the global control rate of hypertension is only 14%, and that's with a blood pressure target of less than 140/90. If we adopted the new US guidelines, which say aim for less than 130/80, this would probably be 3%. Or 5%. I've not done the modeling, but it would even be less. It would almost be non-existent control. So that's the issue, that's the problem, that's the target. Now that's globally. Some countries are doing better, and some countries are actually even lower than 14%. They're in the single digits. Well, let's look at some hypertension control rates. Well, they always put up, and no matter where I go, they put up Canada and the United States as the gold standard, if you will. And I'm very, very proud being in the audience when I see the US flag, and of course my Canadian colleagues are proud. And this is the data. They hold Canada and the US. Canada's doing a little bit better than we are. I would submit that they have a little bit more homogeneous population than ours, et cetera. Maybe it could be other parameters as well, but not appreciably different. But what's striking to me is we only have our hypertension control rates as defined by 140/90 or less is only 52% as a country. That's dismal when you think of the medications we have, the lifestyle modifications, the education programs, the access, the care, although there's differences and there's disparities. I don't deny that. But that is really abysmal. I'm embarrassed by a control rate showing a control rate of 50% in the United States while they're celebrated. They're holding us up as one of the gold standards, including my Canadian colleagues. In our hemisphere, north and south, if you will, Cuba is next at 36%, but then our other Latin American colleagues from the Pure study are less than 20%, almost to the mean of the global control rates. So we have a lot of work to do. And it was these numbers that sounded the alarm to the Pan American Health Organization, headquartered in Washington. And again, 5 years ago, my phone rang, and I attended a series of meetings in Miami, which now has led to the data that I'm going to show you today, and also the clinical consequences or the clinical implications now of the data, because the program is a little more robust, although still in its infancy. We started, and they locked us in a room. And by the way, you can see this heart's emblem up there. And somebody asked me in the audience, if you want to look at the entire technical package from the CDC and the World Health Organization, just Google Heart's technical package. And you're going to see 6 different modules of all sorts. One of the modules is completely enveloping, for the most part, what I'm going to tell you today. But Heart's technical package, it's the first thing that'll come up, will be 6 modules, 5 of which are available, 1 of which is still in progress. But we talked about why are the control rates so poor? Why are global control rates 14%? Why are US control rates only 50%? Well, we talked about patient barriers, we talked about healthcare provider barriers, and we talked about health system barriers. And you can read these as well as I can. At the end, I have references. All of these papers came from our group. This is all published. And we've actually published ad nauseum, if you will, but this is all available. I highlighted what's in red only because what we're going to talk about today addresses specifically these barriers, although there's overlap, of course, and there's unintended consequences, and there's positive consequences of targeting one barrier which influences other barriers in a positive manner. But some of the major barriers that we experience on an individual provider level and an individual patient are listed in red. And they span the 3 domains: patient, provider, and health systems. And I would submit to you that one of the most major barriers is us. And I'm going to show you that. You're not going to like it, but it's what's going on. Patient barrier, poor adherence to treatment. We do an outstanding job. We use motivational interviewing, as we heard yesterday. We do all the right stuff. The patient still has trouble adhering. No question about that. Our burden, our fault, our bad, if you will. Therapeutic clinical inertia. What is that? We're going to see it in a split second, I will tell you. It's a major barrier to controlling our individual patient and a major barrier to controlling populations, and that's us. And also lack of adherence to guidelines. There are plenty of hypertension guidelines out there. None of them are wrong in themselves because they're different bodies, they're experts, they're deliberative. We don't follow them. Some of them, it's the guidelines' fault. They're books this big, and we can't even understand them or read them. Yeah, that's on the guideline committee. But some of them are simple and reasonably straightforward and summarized. Okay. And of course, there's complex medical regimens. Pharmacologic regimens is basically what I'm talking about. We put this in the health systems bucket, if you will, to put it somewhere. It could obviously be distributed. But we felt that this is a health systems issue if we are taking care of individuals in a population manner, if you will. But these are the 4 major barriers that some of the initiatives that we've developed, implemented, and we have initial results target these 4 major barriers. Clinical inertia, therapeutic inertia. What is it? Clinical inertia is us. We have met the enemy, and it's us, right? That is the failure of a healthcare provider to either initiate therapy or intensify therapy when it is absolutely indicated, when no one would question that there's evidence, there's guidelines, it's standard of practice to do X, and we don't do X. That's therapeutic or clinical inertia. Now, there's a lot of good reasons that we act that way. We're humans, there's human nature, there's complexities, we're busy. I'm not trying to excuse it, but I'm trying to explain it. We're not doing it on purpose, of course, but we're still doing it. What's the data? Well, this is not new. This is the VA administrative study. I believe it was in the 90s. Yep, 1998. New England Journal of Medicine, extraordinarily prominent journal, distributed widely in the United States and, of course, around the world. The VA study has open access as best as we can. It's free. You don't pay. The everything on a systems level is there. Granted, we can still do better in the VA system. But nevertheless, despite one of our veterans having 6 visits per year, they saw a provider 6 times in a year. 40% had a blood pressure greater than 160/90. only 25% had a blood pressure of less than 140/90, which even in the 90s, that was the goal. So you can see, despite seeing a provider 6 times that year, only 25% of this population were controlled. And it wasn't just one VA, it was a collaborative of 5 VAs. If therapy was initiated or intensified, the systolic blood pressure fell, no brainer. If there was therapeutic or clinical inertia and a medication was not initiated or intensified, the blood pressure rose. So what did the VA authors of this article conclude? That clinicians do not aggressively treat hypertension. I'm sorry, we don't. But there's a lot of good reasons for that. It's not about blame, it's about moving forward. This is, well, you could say, Dr. Petty, this is only one study. That's the VA. That's not my health system. That's not me. That's not my, oh my gosh, not at the University of South Carolina School of Medicine. We don't do that. Well, we do. And some of it is human nature. This is looking at it a different way. And it's a more recent study in 2004. What colleagues of Andre and al. Published in the Managed Care journal was, how likely are we to intensify medications, hypertension medications, based on the blood pressure level? Okay, let's look at that. If the blood pressure is greater than 180, so the patient comes in, the systolic blood pressure is greater than 180, 55% of those patients left without any change in their medications. Was it initiated, intensified, whatever? So only, put it another way, 45% of blood pressure medicine change occurred. That's therapeutic clinical inertia. Well, what happens, because no one in this room would argue you shouldn't do something with a blood pressure of systolic blood pressure of greater than 180. However, it gets more interesting. As the blood pressure, the presenting blood pressure becomes less, 170s, 60s, and 50s, more patients left without intensification of their antihypertensive regimen. And this isn't talking about 140 over 140s or 130s. We're talking about patients that came to a provider with systolic blood pressures in the 150s. Only 13% had their medications adjusted or intensified. 87% left without it. I have done this. The patient tries to, oh, Dr. DePay, that's only one reading. I had a fight with I had a fight this morning. I couldn't find a parking space. That is true at our clinics. I got a ticket or whatever's happening. And it's just, no, the blood pressure's elevated. And then we also make the same rationalizations because we're humans. So anyway, that's pretty striking. Again, I showed this data to our system, and everybody said, not us. We don't do that. That must be in Charleston, not Columbia, or that's North Carolina, not South Carolina. Well, no, it is. Here's South Carolina. Actually, it bridges North Carolina, South Carolina, and Georgia, with South Carolina being the hub, so we have the majority of patients in this study. The same thing happens in our own locales, in my own state, in my own home, medical school and medical center. What this shows is, and this is 62 practices, not one here or one there, of all sorts and sizes, from solo practices to groups. Over 7,000 patients were in this study. We found that if the blood pressure was greater than 140 over 90, 87% of patients left without a change in their blood pressure medication. Similar to the data I just showed you. So clinical inertia was present 87% of the time. A medication wasn't intensified or adjusted. And if you added a medication or adjusted a medication, the blood pressure went down in the bar graphs, and your control rates improved. Of course, that's just common sense. So it had clinical implications. So let's take that as baseline. What can we do? This is the Hearts in Americas program from the Pan American Health Organization and the CDC. It started as the Global Standardized Hypertension Program. It's now morphed to Hearts in the Americas in the Caribbean and in Latin and South America. And now it's been so successful, at least at an implementation stage, The World Health Organization of the CDC has adopted this program, and now we call it the Global Hearts Initiative, the GHI, for purposes. But I will show you some programs, data, and how we approached it outside the United States with lessons learned that I can bring back to you today. It's a hub and spokes model. We have a Northern Caribbean hub, a Southern Caribbean hub, a Northern South American hub, and a Southern South American hub, and then, of course, some spokes to cover the region. Well, what modalities did we actually even think might improve hypertension control rates? Remember, the hypertension control rates in the Hearts in the Americas program is about 16 to 19%, on average. So they're dismal. So we have a lot of, this is low-hanging fruit. We can do a lot of good with maybe a little effort because, unfortunately, the control rates are so low. Well, number one, would a standardized and simple antihypertensive formulary help? Instead of having 110 blood pressure medications available, like going to a candy store and having all this choices of candy around you, would it help if we simplified the formulary and standardized it according to local culture, needs, availability, economic factors, in addition to others? Would that help? Would combination therapy help, either by single pills? What I mean by SPCs is 2 pills, given at once, though. And FDCs, fixed dose combination, the definition is 2 antihypertensive medications in 1 pill. We don't care how, but would giving 2 medications at once, either in 2 pills or in a single fixed dose combination, would that help? Would an algorithm help? Would a simple and standardized algorithm help that a health system a clinic could use, a health system could use, a region, a state could use, or the nation could use? Would that help? And then finally, would creating a hypertension registry with timely feedback to providers and using team-based care help? That was another outcome of the initial Miami studies. These were possible hypotheses, if you will. We'll talk about the first 3. I can already tell you the 4th one is essential. So just leave it at that. Well, standardized and simple antihypertensive formulary. If you're going to develop one, what are some of the parameters? And what I mean by this is having as few antihypertensive medications as needed. We'll talk about how we do that and what that might look like. Would that help? Would having 10 that you choose from help rather than having 140? Would that make any difference in our clinical inertia, therapeutic inertia, patient acceptance, pharmacy, interacting with our colleagues, team-based care, et cetera? Minimal drugs as possible was one of the rules. Second rule was establish a primary agent, and then, if there's a secondary agent, one as well. So a primary and secondary, not tertiary, quaternary, whatever 5 is, or whatever 7 or 10. 2. Now, of course, these are just rules. They're made to be broken, as you're going to see. But that was another guideline. And establish a single pill and fixed dose combination formulary if you could. But the initial thing was just single pill formulary. Well, how did we do that? And you could do this on a local level as well as a national level. The same rules apply. You got to get experts in the room, and you've got to have stakeholders together to do this. And you got to just close the door, say you're not leaving until we have a formulary. You can provide whatever you want to provide. Good food, fruits, nuts, berries, martinis, I don't care, as long as we get the process done. And that's what they did. They locked us in a room for 2 days in Miami, and we duked it out. And it was interesting because, remember, we had different languages, different countries, different continents. You'll see the results. Determine the pharmacologic classes first that you're going to use to treat hypertension. Then within those pharmacologic classes, pick a primary agent and a secondary agent where possible. And then finally, consider pharmacologic combinations. You've already seen that twice. I don't have to beat a dead horse, but I'm going to beat it again. And by the way, I'm at least most of my career from Texas. When your horse is dead, it's time to get off. And this is what we came up with. Remember now, this is a formulary for low and middle income countries. This may not be the formulary you would develop in your clinic or your health system. It's just an example. And I can tell you that this formulary has already been broken. It's been broken by all the low middle income countries that have already advanced and have already developed new formularies with newer agents that are available. Now they convince their health ministries or their health systems to purchase because of this initial formulary. But it just goes like this. Here's the classes. Very simple. Diuretic. Yeah, we need a diuretic. We need a primary and a second diuretic if possible. I don't care what the agents are really on the formulary because it can change so rapidly locally or et cetera. But chlorthalidone was the primary. I can tell you that in low and middle income countries, it's not available. By and large, so the secondary one was hydrochlorothiazide. But the primary one, the goal was chlorthalidone. It's longer acting, it's more potent, it lowers blood pressure better, no question. Now, can we get it? And can we get it at an affordable price even though it's generic? But still, we're aspiring. You need an ACE inhibitor to treat hypertension. You can see lisinopril. Enalapril was the backup. That was only because of two countries. Bolivia and Cuba only had enalapril. That's why there's nuances here, but it was fun. It's just the idea. It's not the agents that are on there. As you're going to see, I'm going to show you they're already changed. You need an ARB. You need an angiotensin receptor antagonist, we decided. As a class, well, there's losartan and valsartan. You need a CCB to treat hypertension. There's only one. Amlodipine. Notice there's no second. There's no backup. Not verapamil, not diltiazem, not gosh knows what other ones. Amlodipine. Simple, right? Everyone's going to use amlodipine, right? And we put a beta blocker up there not because of hypertension, but to treat coronary disease, et cetera, concomitant comorbid diseases. So there's beta blocker, bisoprolol, metoprolol. And other for resistant hypertension, if you want to go further, after 3 agents, we actually added spironolactone, and the Pan American Health Organization went along with that. And you can see there's no other backup. The backup would be a pilrinone, too expensive, et cetera, don't need it. We just put spironolactone. Very simple. How many agents? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That's all. Now, they could be 10 different ones. It's just the concept. Then we dreamed a little. We put down some fixed dose combinations, possibly, that we would aspire to. None of them were available, as you can see. And then we dreamed a little bit more as to what, if you build it, they will come. What combinations, if we started putting it out there with the pharmaceutical industry, knowing that we're talking about 1.4 billion people, you get their attention. Because, my goodness, can you imagine how many tablets they would sell, even if it's a penny? They'll make money. They're not going to be, they're left out. Would they start manufacturing them? And that's exactly what happened in Cuba. We started with enalapril. They've already moved to lisinopril. It was kind of easy in Cuba. The government just said, Dr. DePetty, which drug do you want us to have? I said, lisinopril. Fine, we'll just tell them to make it. That was done. I said, that's not bad. Could you come to my health system and do that for me? Anyway, so that was the formulary. Let's talk about combination therapy. Same thing holds true. Whether it's 2 pills at once, single pill combination, or it's fixed dose combination, 2 medications in 1 pill, the process is the same. Establish the classes of antihypertensive agents that you want to use, or your primary classes. Establish drugs within each individual class, and then establish combinations and permutations around that. Again, taking into account culture, affordability, what's available, et cetera. This is not a one-size-fits-all. The process is what we hope is one-size-fits-all, but it's easily modifiable, as you're going to see, to whatever area, country, geography that wants to start implementing the program. And you're going to see they're completely different agents, not classes, but agents when I show you some of the data. Well, the first burden we had was there was resistance to this. There was ministry resistance. There was governmental resistance. There was provider resistance because they weren't used to combination therapy. The ministry said, Dr. Petty, we can't do this. We don't even have the single drugs yet. I get it. We can't afford it. I understand, but let's aspire. Let's just put it out there. Let's put a best practice out there, and let's see what happens. No fault, no bad, no blame. It's not new, and that's the first thing we had to convince people, including us in this room. Actually, the landmark trial that led us to start pharmacologically treating hypertension was conducted in our VA system here in the United States in the 1960s. It was the very first study. It took veterans with severe hypertension. One group stayed on placebo because there was no treatment, there was no known evidence for treating hypertension. And the other group got what? They got 3 medications at once. So they got a triple pill combination of a diuretic, a sympatholytic, and a vasodilator. So one group of veterans was given 3 drugs at once, and one group of veterans was given placebo. And we all know that study was so positive, they only needed 70 veterans in each arm to stop it, because the triple drug therapy lowered the blood pressure, strokes went away. We talked about accelerated hypertension, malignant hypertension, none. Renal progression of renal disease, almost none. MIs decreased, et cetera, with only 70 veterans in each group. Stop. Right? But the point of the story is they used triple drug combination therapy, and somehow we lost that in the process over the years. But that's how we started. Well, most guidelines do recommend considering starting 2 drugs at once, or combining drugs if they're already on it. I'm more interested in the starting 2 drugs initially. JNC7, we talked about that a few days ago. JNC7 recommends, and this is now in the early 2000s, 2003. My mentor chaired JNC7, Dr. Trebanian from Boston University, where I trained for my postgraduate training in internal medicine and hypertension and vascular biology. And they said that you can consider 2 drug therapy at once initially if the blood pressure is more than 20/10 away from the goal that you establish. So if the goal in JNC7 was, we'll just put it mildly, less than 140/90, you can consider starting 2 drugs at once as initial therapy at 160/100. If your goal's lower, you've got more, but that's the easiest way to explain it. So it's been in our guidelines. And are we doing it? No. The other caveat is almost 80% of our hypertensive individuals will need 2 drugs anyway. They're going to get there. So start with the end in mind. I've heard that many, many times in life. Well, let's start with the end in mind. If 80% are going to need 2 drugs, why not start with 2 drugs? And if we're going to use lower goals like 140/80 or less, 100% or almost 100% of individuals are going to require 2 drugs to achieve those blood pressure levels. Well, let's fast forward. But we saw these guidelines again 2 days ago on the thresholds and goals. I didn't show this slide because I knew it was going to be today. And that is the ACCA guidelines also recommend considering 2 drug antihypertensive therapy initially, when hypertension is initially diagnosed. Again, though, the level was greater than 20/10 away from their goal. But remember, the goal is lower in the ACCA guidelines. So if it's 130/80 or less, that means 150/90. You could consider starting 2 antihypertensive agents at once, either as 2 single pills or a fixed dose combination would even be better for adherence, complexity of regimens, et cetera. So it is in our guidelines. The Europeans went even one step further. The European guidelines, which came after the AHA guidelines, even though they didn't change the classifications, they are the first deliberative body that said, wait a minute. In our guidelines, we should be actually proposing guidelines to address specifically hypertension control rates. So individual guidelines, of course. But now they took a step further and said, our control rates are so abysmal globally, no matter where you are, even in Europe, high-income countries, they're no better, that they're so abysmal, let's think about putting in guidelines, some parameters or mechanisms or modalities that will hopefully target improvement of those control rates. And they focused on combination therapy. And in the guidelines it says, please, please, please consider starting 2 drugs initially for all patients that you diagnose with hypertension. That now includes 140/90 or greater, because remember, they didn't change the classification. They're the first body that is saying, even with whatever the diagnosis of hypertension is, whatever your diagnosis, 140/90, 130/80, they didn't go that far because they didn't recommend 130/80, but at least 140/90, can strongly consider starting 2 drugs at once, particularly in our high-risk individuals. In our country, that includes our Black African-American population. Strongly, strongly, strongly consider that. Even our own guidelines say in certain demographic groups, including Black African-Americans, consider 2 drug initial therapy at once. So, if we get past that hurdle, which ones? Now we've got to think about the classes that we would want to include in a 2-drug combination. By the way, this lecture, or this time for us, is talking about 2 drugs at once. We may be back next year, and we may be talking about 3 drugs and 4 drugs at once because the data is already out. That might even be another strategy to entertain for various reasons. But let's just talk about 2 for now. But it's really moving quickly to 3 and 4 drug combinations. Okay, these are our 3 major classes. Some people say 4. I simplify it to 3. So you might hear there's 4 classes. The reason being the RAS inhibitors, the renin-angiotensin inhibitors like ACE inhibitors and ARBs. The World Health Organization includes them as 2 different classes. So you'll hear 4 classes to choose from, but basically 1 will be ACEs, 1 will be ARBs. Certainly another class will be diuretics, and the 3rd class will be calcium channel blockers. So those are our 3 classes that we should predominantly choose from. Beta blockers should not be considered as a primary class by many guidelines now, almost all guidelines, probably or predominantly because they may not reduce stroke despite lowering blood pressure as much as the other 3 classes, but we reserve the beta blockers for compelling indications. Certainly coronary disease, angina, et cetera, heart failure, even migraine, et cetera, but they're not one of the 3 classes. So we only have 3 to choose from, and basically 4 subclasses, if you will. So there's not very many permutation and combinations of this. So what are the advantages? Well, most are going to need multiple drugs anyway, so start with the end in mind. Talked about that. There's proven greater efficacy of 2 drugs at once versus optimizing and titrating a single drug to its maximal dose. There's plenty of evidence for that. It allows lower doses of both drugs. Then you're going to improve side effects. And that combination is more effective than titrating to the single drug dose anyway, which takes you more time. Takes another visit or 2 to get there. So why wait? Right? Simplified regimen, clearly better adherence. Every study that's demonstrated 2-drug therapy versus 1-drug therapy demonstrates improved patient adherence. It gets over that, or it helps with that 1 patient barrier. It's not a panacea, but it helps. It certainly reduces clinical inertia because you're starting 2 drugs at the get-go. You're not waiting for 3 or 4 more visits to get to that second drug. Complementary drug classes, when they're chosen, they actually negate any racial, ethnic, or geographic differences in the individual you're treating. When you use 2 complementary drugs together, I'll show you the data. The argument of which one should I start first, Dr. Petty, goes away. Because when you're using 2, you're attacking whatever the genetic or physiologic basis for differences in antihypertensive agents with drugs blood pressure response. You negate that when you use 2 complementary drugs together, when you choose the right classes. And then there's economic benefits. The first thing that a health minister will say to me when I go to a country and talk about this is, Dr. Petty, don't talk to me about this. I don't have any money. And all true. And I empathize. And it's just going to cost me more because they're a little bit more expensive. That's true. That's the purchase of the agent. However, if you look at the downstream consequences, it is actually much cheaper to use combination therapy. But you got to get that health minister over that first hurdle, if you will, of that initial expense. And that's real, and I appreciate it, and I completely understand where they're coming from. But we talk about it a lot more. And some are resistant at the beginning, and then some are accepting it later, and some haven't accepted it at all. That's okay. But we're having the discussion. The two drugs mitigate, when you pick the right classes, you actually ameliorate or mitigate the side effect profile of maybe one or the other agent in that combination. For instance, when you use a RAS inhibitor, whether it's an ACE or an ARB, and use it in combination with a calcium channel blocker, the two most common side effects of a calcium channel blocker, amlodipine, since it's the only one at this point in time, you get heart rate increase and you get pedal edema. When you use a RAS inhibitor already in combination with amlodipine, you markedly decrease the pedal edema and you blunt the sympathetic activation. There's no question about it. Same thing's true. When you use a RAS inhibitor, be it an ACE or an ARB with a diuretic, you blunt some of the side effects or mitigate some of the side effects of the thiazide or thiazide-like diuretic, such as activation of the sympathetic nervous system, because RAS inhibitors blunt the sympathetic nervous system. You can ameliorate or mitigate the hypokalemia of the diuretic, the hyperglycemia, and the hyperuricemia that accompanies thiazide or thiazide-like diuretics, and vice versa. When you use a thiazide-like diuretic in combination with a RAS inhibitor, you blunt the hyperkalemia of the RAS inhibitor, which is a concern. So it goes both ways. This is a two-way street. Is this not a good thing to do? Please say yes. No. So what's the blueprint? I was actually charged by the Pan American Health Organization to come up with a blueprint. How can anybody do this and make some sense of it without being mandatory? Outline or write or publish the process that one would embark upon this journey if they were willing to do it, and it's just recently published, as you can see. I am extraordinarily proud that this paper was used by the World Health Organization, and just last week, the World Health Organization has an essential medications list. That's the Bible globally. If your drug or your agent is on that essential medication list, you're good to go. Every year, it meets every 2 years. Every 2 years, fixed-dose combination antihypertensive therapy has been denied until a breakthrough last week. The WHO just approved 4 combinations to be on the essential medications list. It's been all over the news if you're interested in this area. And I've had 1,000 emails because some of the credit is going to this group of individuals for this blueprint, which was literally handed to the World Health Organization leadership and said, please consider this. And for the first time, we're extraordinarily pleased that we have 4 combinations on the essential medication list for the first time. What's the ideal characteristics of the classes that you're going to use in the medications? They're no different than picking a single drug. And this is adapted from our publication from the initial standardized hypertension program, which was published in 2016 after those Miami meetings that I talked to you about. We published some of these characteristics, but these are an expanded list with just fixed dose combination or 2 single pill combinations at once. You'd want it, of course, to work. They should lower the blood pressure. Right? You want it to have synergistic or at least additive blood pressure reduction. Mitigate the side effects of either agent or both if you can. This is a wish list. This is ideal, remember. Potential for wide availability and affordability. That could be problematic, but that would be ideal. It would be safe and efficacious in a diverse group of individuals if we're talking about global treatment of hypertension. Race, culture, geography, salt sensitivity, whatever is the parameters that you could come up with. And by the way, sex as well. You'd want females and males to respond similarly. Daily, it should be once a day for adherence, et cetera, if you could. A scored tablet we added because some places, if it's a scored tablet, you can split it. And you can save a ton of money if you can split it. Not easy. And not, some systems don't want to do it, but some systems are doing it with great success. So even a scored tablet may be more helpful than a capsule or a tablet that can't be scored. But that's ideal, but notice it's at the bottom. Well, steps in selecting. They're the exact same steps we just talked about. First, pick your classes. Which classes are you going to use? You will pick one of those 3 with 2 subset, one of those 4 subclasses of antihypertensive agents. You will. Then within those classes, select a primary and a secondary agent, just like we did with the initial formulary process. And then finally, select which agents are available to you, affordable, modifiable to your health system, location, insurance providers, health ministries if you're in Uganda or in Bolivia, et cetera. And that's where a large degree of flexibility comes into play. Oops, excuse me. So which 2 classes? We agonized over this. One of 4 permutations. We preferred, because of evidence-based medicine, to select a RAS inhibitor, if you will, an ACE or an ARB, in combination with amlodipine, a CCB. I say amlodipine interjectively, it's the only one. So, and a CCB. Now, within those, you can have 4 permutation and combinations. You can pick it with a calcium channel blocker, preferred, or still acceptable as with a thiazide or thiazide-like diuretic. If you notice, the ARB combination within each is on top of an ACE because of tolerability. So you can avoid the cough and you can avoid the angioedema. On the other hand, if cost is a factor, you can see first, we would first say is preferred is an ARB and a CCB combination. Second preferred is an ACE inhibitor and CCB. And the only reason the ARB is ahead of the ACE is tolerability. Then an ARB and a thiazide, and then an ACE and a thiazide. And that's because there's more evidence with RAS inhibitors and CCB than there is for ACE inhibitors and thiazide diuretics. We did not put down CCB diuretic combination as preferred. We put it as non-preferred because there's just lack of evidence. It doesn't mean it wouldn't work or we shouldn't entertain it. We're going to talk about pregnancy. That is where this will fit in. The ACCOMPLISH trial. What did we base these decisions on? Very quickly, you know these studies. The ACCOMPLISH trial was the first study to compare 2 drugs to 2 drugs. Not which drug is better, but which 2 drugs is better. They compared an ACE inhibitor, benazepril, with amlodipine, a CCB, against benazepril and a thiazide-like diuretic. Remember, those are all on our list. So they're preferred or acceptable, but they compared them within each other. And this is why the RAS amlodipine jumped ahead of a RAS diuretic, because of the ACCOMPLISH trial. And it clearly showed the study was stopped early because there was greater benefit to the ACE inhibitor CCB compared to the ACE inhibitor thiazide diuretic. There were less cardiovascular major events. And so this is the evidence to support the recommendation. Well, what about newer studies? This study just came out. You probably either saw it, passed over it, et cetera, because you couldn't miss it in those finer medical journals like CNN, or USA Today. But nevertheless, it was all over the place. The CREOL study just came out, New England Journal of Medicine. It studied several African populations, obviously black populations from Africa, sub-Sahara, and compared, again, for the first time, combinations against one another. Not which drug works better, which combination drug works better. And they chose 3 combinations. We were very delighted that they picked ours. Our paper wasn't out, so we can take no credit. But notice they picked RAS inhibition and either amlodipine or thiazide diuretic. They did not choose an ARB because that wasn't available in the locale, if you will. Those are the doses. They automatically doubled them at 2 months if the blood pressure was still greater than 140/90. And the endpoint was not control rates. It was just which ones lowered the blood pressure the best. Well, surprisingly, here's the change. And they did 24-hour ambulatory blood pressures, not just office blood pressures. The amlodipine ACE inhibitor and amlodipine thiazide-like diuretic decreased blood pressure better than the ACE inhibitor hydrochlorothiazide combination in this very, very homogeneous population in sub-Saharan Africa. I think that if they had raised the dose of the thiazide diuretic, they all would have broke even. And even if they did, that would still be beneficial because in a very salt-sensitive, very genetically homogeneous population that's at high risk for hypertensive target organ damage, the combinations were highly effective. Notice how much they lowered the blood pressure. And they were given at once. They didn't wait. Try one, titrate, come back. 2 years later, you finally get the patient back and you start over again. No, they treated them the same. We learned this lesson from our HIV colleagues. I was actually, another time, I was invited to the HIV guideline, the global WHO HIV guideline committee. Why me? I know nothing about HIV. Well, HIV patients are now, of course, wonderfully controlled. It's a chronic disease. They brought me in because what are they experiencing now? Stroke, hypertension, heart disease, diabetes, and obesity, Dr. Pisiak. So for the first time, they're going to include non-communicable diseases in their guidelines, and they wanted some help. But what I learned was, in our HIV population, they have a 90-90-90 rule. We should do this with hypertension or blood pressure. 90% detection, 90% on treatment, and 90% controlled. And they mean undetectable viral loads. The minute a person goes, no matter what clinic, everywhere, this is predominantly Africa, because 80% of HIV is unfortunately in our African colleagues in our African population. Once that strip comes back, that fast test, if it's positive, anybody in the clinic, and it's almost never a physician, any healthcare worker can dispense 2 retrovirals at once that minute. They're not waiting for labs, they're treating. That's incredible, because we often worry about, well, what about 2 drugs? My goodness, these are retrovirals and antivirals. And they have 90% control rates with 0 viral loads. I would do cartwheels if we had 90% control rates for hypertension. So that's where we learned some of this from our other colleagues. So here's the combinations. Getting more specific to drugs, and again, these are just examples. ACC, an ARB and CCB, any long-acting ARB. Valsartan could have been on that too as well. We just ran out of space. They're just examples. And amlodipine. Well, what about an ACE, a long-acting ACE, and amlodipine as a combination, whether it's fixed dose or give 2 drugs at once? What about others? ARB plus thiazides, chlorthalidone or hydrochlorothiazide is the only difference there. We prefer chlorthalidone, but we know it's not largely available, so hydrochlorothiazide and then ACE and a thiazide or thiazide-like diuretic. It's very simple, and it's very straightforward. So let's conclude with this. Consider, this is this portion, consider fixed dose combinations. Recommend therapy even now as initial therapy according to our European colleagues. Develop an algorithm with these agents. Don't just select them, but then put them into an algorithm that is primary care oriented, treats the exception, not the rule, and has timely monthly visits. Our algorithms, you see the patient back once a month until they're controlled. These are examples. They're in the references, and they're on the HEARTS program. The E module is evidence-based module. I'm just referring it to you. There are several different algorithms that you can choose from. Just for instance, one starts with a diuretic as first-line therapy. These are single-pill algorithms, start with one, titrate, add another, et cetera. And you can see it goes through the drill. Thiazides, RAS inhibitors, add CCB later. This could be all kinds of permutation and combinations. Pregnancy, of course, can't use RAS inhibitors. That's where your CCB and your thiazide or thiazide-like diuretic would come in. There's doses there for you. Only 2 dose titrations. We did away with the little dose. It's not effective. It's clinical inertia. It's therapeutic inertia. We recommend start with a half maximal dose. Only 2 steps for dose titration. Saves steps. Attacks clinical inertia or therapeutic inertia. Somebody asked yesterday about the non-pharmacologic lifestyle modifications. There they are. They're plastered all over the evidence-based module, and then there's a module. The H is for healthy lifestyles. So the H module is totally devoted to healthy lifestyles, motivational interviewing, etc. So there they all are. All this is for you, so we don't have to review it this morning. I'm just showing you that it exists. Another one is with just permutation and combinations. We did another one with CCB first, amlodipine first, then RAS inhibitor, then thiazide. It doesn't matter, it's just an example. we did one with a RAS inhibitor first. So if you like that one, that smorgasbord, you can choose that one, or something like it. But more importantly, this is the one we want, which we're moving to is starting the 2 drugs at once, in combination or as 2 single. Notice the difference. Look at this one. Look how long that is and how many steps. Boom. Look how much easier it is when you start with 2. It'll only take you 4 steps to get to hypertension control rates if we start with a combination therapy, if you will. And again, there's the doses. Examples of evidence. Kaiser Permanente has been doing this for at least now 11, 13 years. This is their algorithm. This is the one I showed a couple years ago, just as food for thought. They're still using this algorithm. It starts with an ACE inhibitor and a thiazide, lisinopril and hydrochlorothiazide. They'll probably move to an ARB and a CCB when they make that giant step, because they've done so well with this. If it ain't broke, don't fix it. So they may not want to fix this because it's not broke. Very quick steps. Add a calcium channel blocker, add spironolactone if you want a 4th drug. Their control rates started at 44%, lower than the California average, lower than the United States average. They're now at 90% control rates. That's the only intervention they did. And I talked about demographics. If you use 2 complementary drugs together, the control rates are equal no matter whom you are, at least at least what we can detect. Whether you're non-Hispanic white, you're Hispanic, you're black, you're Asian Pacific, et cetera, their control rates are all the same. There's no discussion about which drug is the better one, et cetera, anymore. Doesn't matter. Talk about simplicity. This is now the Hearts in the Americas program. I showed you that initial formulary. Well, it's morphed and it's evolved. Our 4 starting countries, we're now up to 12, but this is our 4 that has had the longest experience: Barbados, Chile, Colombia, and Cuba. Notice the fixed dose combination. They all have an algorithm. They all have a formulary, a small formulary, and there's the fixed dose combinations they use. One's using lisinopril and hydrochlorothiazide, the Kaiser Permanente program, although Barbados just switched over to an ARB, CCB protocol a couple months ago. ARB, amlodipine, losartan, it doesn't matter the 2. But they're complementary, and they went through the same process. And they're already changing them from the ones they started because of success, health ministries, excitement, enthusiasm, and availability, because if you build it, the pharmaceutical industries are delivering it. Control rates are going up, even within 18 months of starting the program in Barbados. Cuba's experienced a very robust increase in control rates. It says 35% there. That's not true. I apologize. That was during the hurricane that they had, where everything came to a grinding halt. They're back up to 80%. Colombia's at 75%, and Chile's at 87%. Remember, they almost all started around 14 to 30%, depending on the local milieu within that country. This is dramatic success. So let's stop. Use a standardized and simple approach to CVD and risk assessment. And notice Dr. Piziak, diabetes is up there. I did not talk about diabetes, but there's also a module for diabetes that gives you the same blueprint for diabetes. Determine blood pressures with validated equipment. Use a simple and specific and limited formulary and algorithm. Strongly consider fixed dose combinations or single pill combinations as initial management. And now we have plenty of guidelines. We have plenty of green lights, permission to do it if we want. Now the question is, are we going to? What settings should we? What settings shouldn't we? Sometimes it may not be able to be adopted. Again, for good reasons, that's okay. But this is where I believe we're going. You're going to see more and more guidelines recommending this, whether they're national guidelines or whether they're even global guidelines. In the future, I'm pretty sure, I can't guarantee it, anything can change, of course, but that's where we're headed. There's some recommended reading for you, and then it's in your list. And this is some of the evidence already that's being compiled by the Standardized Hypertension Program, the Hearts in Americas program. First the program that initiated out of the Miami meetings, our studies with our Barbadian colleagues, looking at guidelines and their implications for the Caribbean. And then, of course, now, what are the implications of using the American guidelines in low and middle income countries. That was just recently published late last year. So there's just some food for thought for you.